Okay. Dr. Wong, Rossini Wong is our moderator. She's been looking through the chat to see what questions you've been posing. So, Rossini, do we have any questions for Michael or me or Dr. Yang?
Yeah, thank you all the speakers for the great presentation. So we've got several questions from the Q&A boxes. There's one for Dr. Barrington from Dr. Mohammed Beshrahil, asking, so for spine surgery, would you recommend retrolaminar block instead of erector spinae block?
That's a big question. And, you know, spinal surgery is so variable. Spinal surgery, there's so many different variants of spinal surgery. I don't have a strong recommendation for that. I'm not aware of any definitive studies. I'd be open to hear other people's viewpoints on that.
Mm-hmm. Any other speakers have any viewpoints for this question?
Sorry, I was in the dark for a little while this was going on. I gathered the question was whether we can use retrolaminar as opposed to ESP.
Yes, correct.
For spine surgery.
That's the question.
I'm not aware of any data that has directly compared one with the other, but the anatomical literature and what even Dr. Barrington presented, that the retrolaminar produces more a longitudinal spread consistently within the area of the lamina and the paralamina area. And if your requirement is in the along the both sides of the midline, then maybe retrolaminar is a good choice.
Okay. Thank you. Next question is, how low concentration of local anesthetic can be used for ESP?
I can see you, PA.
Hello.
Don't go away.
Hello, I will just optimize.
Yes, Michael, can you answer that question?
Who, me? No. I think you're a little bit confounded by the dosage of local anesthetic. So therefore, you know, whether you're doing bilateral or unilateral, but typically I think you need something around the concentration of 0.5% or 0.375% ropivacaine to load it up. But then after that, I think with the catheter technique, you're really committed to using a dilute concentration, something like ropivacaine 0.2 and giving a larger volume intermittently.
Yavuz, would you like to add a few words of wisdom?
Yes, I think, thank you, Manoj. Great discussions and great lectures, and greetings to all our friends and colleagues from all over the world. Most of the time, different concentrations have been used for ESBB, but most of them, the ones also we are using is 0.25% bupivacaine. I think that's equivalent to 0.375 ropi or levobupivacaine.
Thank you. Question from Professor Kamaka from Dr. Lindsay. So she's impressed by your amazing research on the spinal area and would like to know whether you have any consideration of research on adult caudal block.
Thank you for the comment and for your compliments, but I rarely do caudal epidurals in adults. And I think there are some investigators doing this in the chronic pain field. So that's all I can say for now.
Okay, thank you. A question from...
Did you have a question? Professor Lundqvist, did you have a question?
No, I was just trying to make a comment for the question about spine surgery, about
Yes.
the retrolaminar, because the surgeons will open up this area while they're performing the surgery. So I think it might be something that you need to discuss with your surgical colleagues if you will distort the anatomy or create hemorrhage or something like that. So I don't think that, although it's theoretically a place where the ESP block might work, is for back surgery, I don't think that the surgeons might be so interested because it's going to distort their field of surgery. That's my kind of 2 cents on that.
Thank
Okay,
you.
any other question, Rossini?
A question from Dr. Abdulazim asking, is serrated anterior block is superior than erector spinae plane block? I guess after all the presentations about.
That's not the focus of our discussion today, but I think Dr. Gurkan has done some work in this area, so I would like him to add a comment on this.
Thank you. ESPB has been shown to be superior to the serratus plane blocks, and I think I have a slide on it.
Okay.
Okay, it's coming up. And these are related to patients undergoing breast surgery or spine surgery?
They didn't.
Breast surgery. Sorry.
Right. Okay, we'll have an interesting discussion later.
Describe catheter placement.
Are that all the questions for now?
An anonymous attendee would like you to describe continuous catheter placement technique in transverse articular process approach.
Okay. The technique is just similar to placing your single injection. You place the needle close to the lateral aspect of the paravertebral space with obviously a Tuohy needle system. And then you thread a catheter through that. But remember that you mustn't advance excessive lengths of catheter because it could find its way into the epidural space. And more importantly, it may override the vertebral body. This would not be very desirable for efficacy. So today, when I do place a catheter for the thoracic paravertebral, I would recommend you should advance maybe 2-3 centimeters at the most, and then withdraw the needle. Now, coming to this question, as the years have gone by, I'm doing less and less of catheters for these thoracotomy patients for 2 reasons. One is we have good multimodal analgesia post-operative and perioperatively. Second is we perform multi-level injections for our thoracotomy patients. Say we do T3, T5, T7, 3 injections with about 25 mils of 0.5% bupivacaine, whatever you use. Most of our surgeries today, 80% of them are video-assisted thoracoscopic surgery. If it is completed with the video-assisted thoracoscopic surgery, then we don't place a catheter. But if the patient, in about 10-15%, if it requires a thoracotomy, and mind you, they are no longer these days the massive posterior lateral thoracotomies we used to see during our days. They are usually mini thoracotomies, and we get the surgeons to place the catheters under direct vision. So we use the surgical dissection to create a retropleural space, and through which a Tuohy needle is inserted, and then the catheter is placed. And these techniques have been described in the literature. So this has become our go-to for if patients undergo thoracic surgery, require thoracotomy, where the catheter placement. And indeed, some of the stalwarts of post-thoracotomy analgesia with paravertebral blocks like the late Professor Sabbanathan and Dr. Richardson. They described these techniques many, many years ago, including Dr. Beresford. They placed the catheter under direct vision, surgically placed, and it's shown that it produces very consistent cephalocordite spread of the contrast and the local anesthetic, and produces very effective analgesia as part of a multimodal analgesic regime, which they described then as balanced analgesia. However, if you give a patient just a paravertebral block catheter and you don't give them any other co-analgesics, I think you'll be doing them a disfavor. So it has to be used as part of a multimodal analgesia, which often also includes opioids. Okay, this is all I might say to that question.
Okay, one more last question for Professor Kamaka again. Could the out-of-plane approach to the thoracic paravertebral block injure the ventral branch of the spinal nerves?
The ventral rami of the spinal nerve?
Yeah, I think that's
the intercostal nerve.
Yes.
I think it is always there's nothing not possible. I think it is possible. But when you're doing the outer plane approach, it definitely places the needle probably more on the medial aspect of the paravertebral space in compared to the intercostal or the transverse process and articular process windows. But again, there are no reported long-term effects of such injuries being described in the literature or that we have experienced in our clinical practice. But that said, those of us who perform paravertebral injection, it is not uncommon at the start of your injection, you'll often find patients will report some distension paresthesia. This usually goes away in a few seconds, but you will find that as you start your injection and you start distending the space, the patients will often report paresthesia. This, I believe, is because of the distension of the space and probably stretching of some of the nerve rootlets. Now, Professor Nunn, if many of you know, described many in the 1980s that in fact the intercostal nerve, after it emerges from the intervertebral foramina, and in fact this is also seen in Dr. Yang's slides, that once it comes off the medial slit, it actually not a single nerve, it's into multiple rootlets. So these small nerves can distend and produce that paresthesia that are very common. In fact, we see it in about 80% of our patients. But they don't go on to develop long-term sequelae, neurological sequelae. This is all I might say for now.
Okay. I've just spotted one more question in the chat box, not the Q&A box. A question for Dr. Barrington. Dr. Lee from Melbourne would like to ask, so would you use ESP for anterior fracture ribs instead of paravertebral block?
Michael, can you unmute yourself?
I beg your pardon. I would use a thoracic paravertebral block for anterior ribs, fractured ribs. Yeah.
Okay, I think that's all the questions we have now.
Okay. Thank you, Rossini. Thank you, Michael. Thank you, Dr. Yang. And thank you, Yavuz, for joining in. We have, for you participants, we're going to have a short break, 15 minutes. You go and have your favorite beverage, as I always say. We'll commence the proceedings again, and then we will look into the clinical effects and clinical applications of these various thoracic blocks. So until then, bye for now.